Welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
I'm Dr. Brad Weaning.
And I'm Mike Heffernan.
Dr. Heffernan, a cardiologist, he's been on our show before, and we really appreciate everything you teach us. Thank you so much for coming back again today. And what are you going to be teaching us about today?
Well, we had a texting exchange a couple of days ago, and so I think it's going to be atrial fibrillation.
Okay, so you got a little bit behind the scenes look there about how we produce these shows, texting back and forth.
Yeah, it's like 4 texts. It's like, hey, could you talk about AFib? So what actually is atrial fibrillation?
So let's start with what's normal.
Okay.
And if I remember, I'm going to give you a diagram.
Okay.
Okay.
Yeah. So here's a diagram.
So normal. So we all have a pacemaker at the top of the heart. We're born with that pacemaker, and it's essentially the quarterback. So it's throwing the same play over and over and over again. It sends electricity down to the center of the heart. The electricity then branches off and goes to the 2 main pumping chambers below. And that electricity tells the chamber, okay, beat, fire.
Okay, so that quarterback is the
sinus node.
Sinus node. Okay,
Yeah.
we can see that here on the diagram.
Not Mahomes.
All right.
Or Tom Brady anymore.
Or anymore. Okay, so that's normal. The problem with atrial fibrillation is that a whole bunch of rogue pacemakers have taken over, and they totally ignore that quarterback, and they're all starting to just throw the ball at random, each of them. So you can imagine hundreds and hundreds of balls all getting thrown at the same time. It's really irregular, it's really disruptive, and the poor bottom chamber of the heart has to respond to whatever it's being told to do. Okay. And so it responds to each one, and so it fires away. Now fortunately, there's a little bit of a filter there. You know, we kind of the maximum heart rate for atrial fibrillation is somewhere about 150, 180 beats a minute. Fortunately, it doesn't go as fast as 300 or 400 beats a minute, which is how fast the balls are going up top.
Okay.
So we have a filter that protects us.
Okay, so normal heart rate would be about 70 beats per minute. Now this top end of atrial fibrillation is going to be about 150 beats per minute.
Right.
Which still isn't an ideal way to
it's very
walk
uncomfortable.
around and live. All right.
I think what's an important thing for people to know is that our heart has 2 sides. So the right side of the heart pumps blood from the rest of your body to your lungs, and then it goes from your lungs to the left side of your heart, and then your left side of the heart pushes it out through the body. So are we mostly talking about the left side of the heart or the right side of the heart, Mike, or both?
We're actually talking about both.
Yes.
So the pacemaker is actually located in the upper right chamber, but the electricity runs down so that it synchronizes the beating of both bottom chambers,
right,
and the other upper chamber as well. So they're all interconnected, and it's really, it's a beautiful piece of hardware.
Okay, so you've been watching Talking with Docs for a couple of minutes, and you've learned something. Atrial fibrillation is an arrhythmia, so it's an irregular heart rate. It happens when the sinus node, which normally regulates the heart rate, is sending out crazy signals, and the heart starts beating really fast, maybe double normal, and it's not a very comfortable feeling when your heart's racing at that pace. So that's atrial fibrillation.
Right.
So someone who presents with atrial fibrillation, we always like to do this. We talk about what you feel, what happens when you go see the doctor, what tests are ordered, and then how you treat it.
Sure.
What do you feel like if you got atrial fibrillation?
So that's a tough one, because this can range from I feel nothing, to doc, I can't live with this rhythm disturbance. It's driving me crazy. So the I feel nothing is easy. People happen to walk into their family doctor's office. They go in for their routine yearly check. The doctor listens to their heart and goes, that sounds kind of irregular. That doesn't sound normal. They do an ECG. The diagnosis is made, and then we can talk about treatment afterward. The flip side is we have people come into the emergency department here. They have all these palpitations. Their heart's racing. They don't feel well. They're lightheaded, maybe short of breath. And they come in, we do an ECG and go, you're in atrial fibrillation. Let's talk about what we're going to do about this.
Would they typically have pain?
No.
No, not a painful thing. It's not like a heart attack, so I think that's important.
Yeah, so in general, it's palpitations, it's shortness of breath, it's lightheadedness.
Okay.
Those are the common ones. And then there's a group in between, and it might be just fatigue, or they might just feel short of breath. They might just feel off.
Right.
And those are more difficult diagnoses, and that's why if you're just feeling off, go see your family doctor. Because your family doctor with a simple stethoscope and an ECG can make the diagnosis right away. And I think one of the things that's really important before we talk about treatment, why are we worried about this? Like, why is atrial fibrillation a big deal at all?
Lay it on me.
Okay, so the rhythm disturbance itself is not that big a deal. It's a nuisance. We know it. For some people, it can make them feel unwell, and we've got some treatments for that. The problem is atrial fibrillation can cause a stroke, and these are big strokes. These are not little strokes. So if you have an atrial fibrillation stroke, you have a 1 in 5 chance of just dying right off.
Oh, wow.
Okay?
Your numbers are never comfortable.
I know they're not. I know they're not.
I've got to say that.
You have a 3 in 5 chance of having a stroke where you never get out of bed for the rest of your life if you have an atrial fibrillation stroke. You only have a 1 in 5 chance of having had a stroke with atrial fibrillation and kind of walking out of the hospital and being okay. So this is why it's a really big deal to us.
So you go 1 in 5 you're going to die, 3 in 5 you'll never get out of bed, 1 in 5 you walk out.
Correct.
If you have a stroke from atrial fibrillation, but before you panic, we're going to come to some treatment options that can minimize these chances significantly. But we're going to get to that. Okay. So that's why you can't just wander around life with atrial fibrillation willy-nilly.
So the next question someone's going to ask is, well, how does atrial fibrillation lead to a stroke? Why do you get a stroke?
Good. So good question. So if the heart's working well, if the quarterback is the one that's functioning, it squeezes the upper chamber of the heart like this and clears all the blood, just as you can imagine. But with atrial fibrillation, because you have all these rogue pacemakers, the upper chamber is just wiggling like a bag of worms. And when the upper chamber wiggles like that, rather than squeezing, the blood really does not flow through efficiently. And you know that, if the blood doesn't flow, it clots. And so you can get a little clot forming in the upper chamber of the heart. It's usually about the size of a dime. And so that's a pretty big size.
Yeah, sure.
And then if that all of a sudden breaks off and goes bloop and goes up to your head, it blocks a big artery in your brain, and that causes a stroke.
Okay, so that's scary stuff. Scary stuff. Now, atrial fibrillation, just so people might have heard of atrial flutter. Flutter versus fibrillation.
So the risk of stroke is exactly the same. Okay. The rhythm for flutter is a little bit more organized than atrial fibrillation, but essentially our management's identical. Okay,
because I thought flutter was the thing I felt in grade 9 in the calf when this girl I was crushing on came and sat right beside me.
That could be that.
I thought I had
different kind of flutter though.
Yeah, it was. She was
always comes back to your high school.
I know, right?
Well, unfortunately.
Did you marry her?
Thank you for asking, but unfortunately she was more into my friend. He was playing the jock angle, I was playing the nerd.
He was the quarterback, you were one of those rogue quarterbacks.
Yeah, I was more the nerd angle, so no, she wasn't into me, but I got the last laugh because her malignant lack of interest afforded me the time to study for the biology regional contest,
there you go.
Of which I placed top 3. So Chantel, if you're watching, thank you.
So what is the treatment?
Okay, so what's the treatment? The first order of business is if your heart rate's too fast, we need to slow it down. Okay, we need to make you feel better. That's pretty easy. We have a series of medications from beta blockers to calcium channel blockers in particular. Those 2 classes of medications will just kind of slow things down. In some countries, there's digoxin or taloxin. So we use digoxin sometimes now, but it's really kind of falling out of favor. But it is also effective for some patients to lower the heart rate. So that's easy.
And so sometimes this would be like intravenous in the ER, but sometimes would be started oral medications in your family doctor's office. Okay.
Yeah, and actually probably most often in the office, in the clinic.
Okay.
Especially if the patients don't feel too unwell. And nobody likes to go to the hospital if they don't have to go to the hospital.
Especially during the pandemic.
So that's option 1.
Okay. And just quickly, if any people, we have a lot of viewers who are against big pharma, and they have problems with medication. This is not a fight to pick, If you're against big pharma, against medication, leave those comments for another one of our videos. This one is not one where you can say, I don't want to take medication. This is serious stuff, serious risk of stroke, serious risk of death. Medications are necessary here. So
it's not going to be solved with beetroot and garlic, which are
This
very
not.
important
Let's
supplements.
throw that out there. All the people against big pharma, that'll save you some typing.
Last question about the rate controlling agents. And it's going to come. Am I on this forever?
Yeah. I think
unfortunately, because you have an inherent problem with your electrical wiring of your heart that's not going to get better with time.
Yeah, you can tell from the tone of my voice I'm hedging a little bit.
Yes.
Because there are some treatments that we will move to going forward where we might be able to really settle this down and we can peel back a bunch of medications. But it's kind of in the acute setting.
Yes.
We're going to just slow your rate down.
Control the rate.
We're going to make you feel better.
Yep.
And if you're in a little bit of heart failure with this, as sometimes people are, we kind of manage that as well.
And you get into a bit of heart failure because you can imagine your bag of worms of an atrium and your fast rate, your heart isn't working efficiently,
Right.
so it can't maintain your cardiac output. Fluids get backed up and you end up in a bit of heart failure. So
gonna be a follow-up.
this is not an efficient state of heart
Not
beat.
at all.
That's why you end up in a bit of heart failure.
Yeah, and if you actually, I know I'm getting into the weeds, but if you think about the efficiency of your heart, you will lose about 20 to 30% of the output with when this happens. Some people can tolerate that well, but some people cannot tolerate that well. Now, the next important thing that happens at that visit is we need to get a blood thinner started for almost everybody. There are different scoring systems around the world. In Canada, we use the CHAD 65 score. In Europe and the United States and elsewhere, there's a CHADS VASC score or CHADS VASC 2 score. Regardless of where you live in the world, there is a scoring system that your physician will use to determine do you need to be on a blood thinner or not. And it's really just more risk-based. I can tell you that 93% of people need to be on a blood thinner. Wow. It is a very
93% of the people who have atrial fibrillation
need to be on a blood thinner. Only 7% of patients do not need to be.
According to these CHAD scores for risk assessment.
Right.
Thank you, Chad.
Thank you, Chad.
Okay.
And so blood thinners. So in the old days, we used warfarin.
Rat poison.
Okay, so here's a great bit of trivia.
Okay.
So what does warfarin stand for? We've all heard about warfarin and rat poison. We know we can go to Home Depot and pick it up on the shelf. So it stands for the Wisconsin Alumni Research Foundation. So that's where warfarin was discovered. Okay. There were cows that were dying years ago in the 1920s and the 30s. They were eating rotten clover. And this was the active ingredient that determined, it's warfarin in the clover that is causing this problem.
Makes sense. Kills the animal. It's going to stop your heart from clotting.
So yeah. So we need.
I can see the leap there.
So we need to. No, we're not using so much warfarin that it will kill you, obviously. So, and most countries in the world don't really use warfarin anymore. So warfarin was the only thing we had for 50 years. It is very good for preventing stroke and the setting of atrial fibrillation. The only downside with warfarin is that you need to get your blood tested about every 3 to 4 weeks to monitor the levels. There are a lot of food and drug interactions with warfarin, and there's also, of course, the risk of bleeding.
Sure.
So that's where Big Pharma did come into play. So they said, look, we got to find something better than warfarin. It's been the king for 50 years. I think we can do a better job. Right. A number of these medications are actually now going off patent or already off patent. So Big Pharma is not involved anymore, although they developed it.
Right.
And so there are 4 drugs now available in place of warfarin, where you don't need to have your blood tested every day.
Okay.
You can just take the standardized dose, and they are very effective at reducing the risk of stroke.
Okay, excellent. And the one thing about warfarin, I know we've been sort of, talking about how it wasn't the greatest drug. It was reversible. That was a nice thing. As surgeons, we like the fact that it was reversible, because if we had a patient coming in on warfarin and we need to do surgery, we knew how to reverse it. And vitamin K was pretty well the thing we did. Because
Vitamin K.
Right, warfarin, the vitamin K.
And it was really cheap.
It's inexpensive and it was easy to reverse.
nations.
So, and it served us well for many, many, many years. But now we have more elegant medications that people have a more reproducible reaction to, so they don't need to check their blood every week. And those are the novel orals, I guess.
Yeah.
That's actually a good question. So do you need any baseline blood work to find out is this unsafe? Are these anticoagulants unsafe in any population other than people obviously that have a bleeding disorder?
So that's really what we're looking for is bleeding disorder.
Okay.
Is your blood count too low? Is the platelet count in your body too low? The platelets, are part of the clotting mechanism. And a lot of these medications are, people misinterpret this sometimes. They don't have an effect on the kidneys, but they leave the body through the kidneys.
Right.
And so we have to check kidney function just so we know that the kidneys are working well enough so that this can leave your body.
So you just reduce their dose?
We reduce the dose.
Okay.
Yeah. Sometimes if the kidney function is so poor that, for instance, you might have to be on dialysis, these are not medications we would use in that patient population in Canada.
Okay.
Okay, so cool. So blood thinners, we used to have warfarin, we have some newer, more elegant ones now. So atrial fibrillation, blood thinner, you were asking, is it for life? Is it for...
I was going to actually go for the anticoagulant as well. For life?
Anticoagulant for life.
Yes.
Yeah. So that's regardless. So you now have a diagnosis, and there's always a risk, no matter what we do in terms of the drugs we may use to try and keep you out of atrial fibrillation, or we may send you for an invasive management. You know, we may put a tube up into your heart, we may map out where the atrial fibrillation is coming from, and we may freeze or burn away the little circuits that are causing that. So we can do that as a treatment for many individuals, especially people who are experiencing symptoms. For those individuals, we might peel back some of those things I was talking about, like the beta blockers or calcium channel blockers, but the blood thinner almost always stays. Because while those are great treatments, they're not 100% effective. It's not like surgery, where it's 100% guaranteed that you're going to save the day, right? This is a little different.
So I would say there's a 100% chance that you're going to get your knee replaced. There's not a 100% chance that you're going to be 100% happy. Most people are very, very happy, but but it's going to be solved. I would agree with that.
Yeah.
All right, so that is, and now what about new onset atrial fibrillation? Any sort of less invasive procedures we do to convert people back into a sinus rhythm?
Yeah, so that's where the emergency department comes into play. Just talked to a lady last night who called my office and said, look, she has this diagnosis. It comes and goes. I guess we didn't talk about that. Some patients, atrial fibrillation is there all the time, but for many people, it comes and goes. Normal rhythm, not normal rhythm. Normal, not normal. So she calls the office. Hey, Dr. Heffernan, I'm back in this rhythm. I feel terrible. And I said, okay, you know what to do. I just need you to go to the emergency department. I'll call ahead. And the emerge doc will see you. They're going to slow the heart rate down, make you feel a little bit better. You're on your blood thinner. You've been taking it religiously. Now they're just going to put you to sleep for about 5 minutes and shock you back to a normal rhythm, just like you see on the TV.
Clear.
Yep.
Yeah, love that.
Simple procedure. An hour later, she can leave the hospital back in a normal rhythm, feeling well.
And how often can you do that? Like, is that something that she would do regularly, potentially? Or?
Yeah, well, you can do it a lot. It doesn't hurt the heart. It's uncomfortable for people, right?
Sure. It's not a practical way to live.
And it's not a practical way to live.
So you just would change your medications.
You would change the medications or the management. And I guess there's a class of medications we haven't discussed called anti-arrhythmic medications. These are medications that are specifically designed to try and keep you in a normal rhythm. We tend to use those medications before we float something in your body and trying to burn or freeze things away. They're okay. They're not perfect. They work probably about 50% of the time. And the irony is the one that's the most effective has the most side effects. And so while we use it in some individuals, we really often don't like to, and only kind of use it if pushed. So it's a difficult diagnosis to have for the patient. And you should also recognize that it's also difficult for a physician on the other side of the table, because we've got great medications for other conditions. We don't have great medications to try and keep you in a normal rhythm. We have great medications to prevent stroke.
Okay. Last question I would have, because someone's going to ask this for sure. So, did this happen because of something that they did? And is there anything, and I think I know the answer, is there anything they could do to reverse it? Some people are like, what if I exercise? What if I change my diet? What if I'm really strict and I just live a perfect life? A, could that prevent it? And B, can it solve it?
Dr. Weening has eased us into the risk factor discussion, part of our video. What are the risk factors? And I'm afraid to ask this one because my father, he was a great man. May he rest in peace. He had atrial fibrillation. Now, so I can live in peace. And I'm afraid to ask the hereditary nature of it.
Super small component. Hereditary, super small.
Okay.
So when I give this lecture to family doctors, the thing that I try and instill and remind them is the 3 most common causes of atrial fibrillation is hypertension, hypertension, and hypertension.
Okay, what about hypertension? Does that play a role?
So that's blood pressure control. So if you have poorly controlled blood pressure, it will just stretch your heart. It stretches that upper chamber, and it can give rise to atrial fibrillation.
Because it's just pushing against so much resistance that it's just too hard. It wears it out. Wears out the pump.
Yeah, it starts to wear it out, and the upper chamber is quite thin, and it's easy to stretch. So
we have a video on hypertension and your blood pressure, so check that out.
Good reason to treat it.
So make sure your blood pressure is well controlled. Next is sleep apnea. So also a very common cause of atrial fibrillation. Yeah.
know that one.
So if your loved one or if you, often people don't know it themselves,
Yes.
but if people complain that you snore, not so much snoring, but if you seem to stop breathing when you're sleeping, if people are nudging you because they think that you're dying every night and they need you to breathe again, then you probably have sleep apnea. You should have a sleep study to actually confirm it. But sleep apnea is a big cause of atrial fibrillation. So much so that the guys that go in and the gals that go in to do the freezing and burning often won't do it unless you've ruled out sleep apnea as a cause, because it's really treatable.
Right.
I got to go get my affairs in order.
Yeah.
Okay. So sleep apnea is a big one.
There you go.
Hypertension, sleep apnea, which
Yeah.
is treatable, and I think we have a video coming up.
Yes,
We're
it's
working
coming.
on a video.
Okay,
coming.
We're doing
good.
background research on the sleep apnea video.
Thyroid function we always check, because if somebody's thyroid is overactive, that might lead to it. Those are the big ones.
Okay.
Okay. That's, I tell you, I've learned so much about atrial fibrillation this morning, and it's a very, very useful video.
I got one more question. You know, now there's a lot of fancy watches available, wearable technology. I've got one of those watches. It can tell me when I got to get up and sit down. It can tell me what my
When to
message
breathe.
when to breathe. Ironically, it doesn't really tell me the time, or I can't figure out how to do that. But it can also detect atrial fibrillation. Do you trust these wearable technologies for this kind of stuff?
So it depends on the manufacturer. So Apple actually has a medical grade ECG. I know it's Health Canada approved. I'm pretty sure it's FDA approved.
Okay.
I'm not aware of the other health agencies in the world. So it is trustworthy as a single lead ECG. That has its own kind of difficulties. But yeah, so I wouldn't start somebody on a lifelong blood thinner based on an Apple Watch ECG reading, but it would prompt me then to do additional tests with more sophisticated measures to just absolutely confirm it.
Well, and the diagnosis of atrial fibrillation does not need a ton of expensive tests.
It does
It's
not.
basically the stethoscope is your first line of
and some very
investigation.
simple monitors that we can have people wear for even a couple of weeks.
Okay.
Yeah.
That is an awesome summary.
Wow.
Yeah.
Yeah.
That's a lot.
Is
a lot-
we're
lot
going
to-
to see. Yeah, it's
a
going to
lot
all
to
fit in
take
one
in.
video.
Yeah.
You might have to press pause and watch this video and
Get
Stages.
a coffee.
But if you like it,
don't binge this video.
don't binge. But if you like it, please like this video and subscribe to our channel.
And remember, you are in charge of your own health.
Thanks again to Dr. Heffernan for joining us today.
Thank you so much for discussing matters of the heart.
Thanks for having me, guys.
We'll see you next time.